I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm excited to have with us today Dr. Rees Checketts. He's a resident over at Creighton University. I'm excited to have you on board here because I imagine you represent a lot of our listeners.
I certainly hope so.
Yeah.
This is something that's interesting to me. It's something that, finance in medicine is an enormous aspect of what we do, but as residents, it's really hard for us to wrap our heads around. So, we've been meeting for a few times in different settings, but I think it's really interesting what I've been learning. So I'm excited to share that today.
That's awesome. So why don't you tell us a little bit about yourself, a little about your background? How'd you get into medicine? What are you doing now? What are you looking forward to?
Sure. Yeah. So I'm a third-year internal medicine resident. My journey started, I always say, when I was the oldest of 8 kids. During that process, mom was having babies, and I was aware of that. And it was just fascinating how the doctors could help. They knew information about our bodies that we didn't know ourselves. And that just led me to just thirst after knowledge. And I wanted to learn that so that I could apply that. I could be a scientist, an ethicist, and a communications person, which I think is the greatest combination that comes together in medicine. So that's kind of what drew me to it. I am third-year resident. I'm applying for gastroenterology. I'll find out in a few weeks if and where that will be, and then we'll switch hats just a little bit, and we'll continue to just pursue medicine. I think I'm drawn to internal medicine. I might bring this up later. We'll see if it fits, but or to gastroenterology because I love lifestyle medicine and gut health and nutrition, and I see direct primary care and other models providing an avenue for that kind of expression.
Sure. Well, that's exciting. And, I wish you luck, and I'll pray for you, obviously.
Thank you.
Leading up to your,
appreciate that.
To your decision here. So let me ask you this. So, you and I met because you had reached out, you were coordinating some stuff for Grand Rounds at Creighton.
That's right.
And there seemed to be some interest in the business model that I had.
Right.
And I don't know if you remember or not, but when we first spoke, I said, I'm happy to come talk, but I think there's a good chance I'm going to piss some people off.
Yeah. I do remember that. And I took a deep breath and said, let's give it a shot.
Sure. Well, I appreciate you trusting me enough to dive into that and to take that risk. And judging from the response that we got at Grand Rounds, it was better received than I had expected it to be.
Same. I wasn't sure what it would be like, but it was fantastic. And people who I spoke with after, who were on different rotations and couldn't make it, they remained very interested in it.
Sure.
I had conversations with different people, and I talked about lifestyle medicine, but we were talking about how do you create a practice where, you're not bound by different, billing necessities, and you could go ahead and you could just carve a lot of your model into, a different avenue. And as we talked about that, you kept coming up because it was this innovative idea that was, and you've told me this before, but it's not just thinking outside of the box. Sometimes it's throwing away the box and getting a new one.
Right, exactly.
And so I think that's what was really interesting about your presentation that, remains with me today.
Sure. So what is it about direct care, whether it's direct primary care or direct specialty care, that really kind of caught your eye and made you sit up and say, what is this? I want to know more about this.
I love talking with my patients, and I really like to spend time with them and get to know them. And somewhere along the line, learning about quotas and how many patients you would have to see, that was something that really, was a gut check. And I said, well, I don't want to have to know everything about medicine, have it be super vast, and then have a very narrow slice of time to try and identify a disease process treat it correctly and get buy-in from the patient. Well, buy-in from the patient and then treat it. Sure. And so the idea of being able to structure a model where you're not necessarily taking a huge haircut, but you're able to still have that knee-to-knee interaction with your patients was just very exciting to me.
Sure. So as you're progressing through your career, obviously most of your exposure has been to academic medicine.
Right.
So what kind of exposure have you had in academic medicine to these concepts of direct care?
So to direct care, it's been pretty limited. I remember back in medical school, we had I went to a lot of lunch lectures. I was looking for free food everywhere I could find it. And we had some doctors who came who were doing more of a concierge model.
Sure.
And they would describe their practice, and looking back now, it does seem to be like a direct primary care, but that was kind of the extent of my exposure. And then during residency, it's mostly just been, navigating the conventional model. And so you're listening to you on a podcast a long time ago while I was in med school was an introduction, some of those lunch lectures, and that's about it.
Wow. Okay. So what have you found? I mean, it's one thing to run across an idea and hear it once, maybe hear it twice. You're like, well, that's kind of interesting, kind of like, I don't know, Tutti Frutti flavored Doritos. Mm-hmm. You're like, well, that's kind of interesting. Right. That doesn't mean you're actually going to want to try those Doritos, right?
Right.
But clearly, in your case, you've continued to look into this further.
Yeah.
Why?
Yeah, it's a great question. Well, for one, I'm a father. I have 3 young kids. And as we've gone through education and early training, as finances have shifted, so has my insurance needs. And so the amount of, what we have to pay for insurance has changed. My wife, myself, our kids, we're all healthy, but it is just this huge task to try and plan ahead for an unforeseen surgery, or to think of, are we going to have more kids if a kid costs X on this insurance model and other things. And so something about the personal costs as to a family is something that appealed to me. But then on the flip side, as we've talked more about kind of the model that these primary care doctors can have, where they can have, a panel of patients, hundreds of patients that they can see for 30 to 60 minutes maybe. The patients aren't feeling like they're paying through their noses, that they're just, being gouged. And the doctors aren't feeling like they're having to meet these unattainable quotas, that there's this model, there's this marriage that might be had, is just extremely interesting to me, and something that I continue to come back to.
Sure. So now, as you consider gastroenterology, obviously, GI is not the same as primary care.
Right.
I mean, there's some pretty significant differences there.
Right.
So how do you see what you've learned about direct care fitting into that model potentially?
So some of the things that I like about that, and what I hope to do, is to create kind of a transparent pricing model, and to have the opportunity available where if a patient knows that they're due for a colonoscopy, they can Google search it, and we can have a price available for a colonoscopy. And we can say colonoscopy with biopsies will be this.
Sure.
Or we could have other models where I'm interested in obesity medicine, and I may not pursue that, but it's something that draws me into primary care and subspecialty. And so it might be something where arranging evening classes where patients could find a price, and it could be, join our group. And in the evenings, you'd be able to attend a class put on by professionals for X amount, and to have that be part of like a transparent pricing model.
Sure.
Whereas just if it's available, you can come and we'll bill you later, and 6 months later you'll decide if it was worth the price or not.
Sure.
So that's kind of what I'm hoping to do.
That's awesome. So then, as we think about transparent pricing, what's the importance of transparent pricing? Why does that even matter?
Well,
in your mind?
Yeah, no, for sure. I think that's a great question. I'll go back to my childhood for just a second. When I was 14, my dad bought me a lawnmower and said, "Here you go. go out, hustle, mow your neighbor's lawns, and you can, when you turn 20, you can go to college, and this should pay for all of your living expenses. This is my investment in your college fund. And he did that to me and my younger brother, and that's where we got started. And so from that very early age, I began to learn the importance of pricing. And we weren't trying to make lots of money or pay for families. And so we were able to come in at a low price.
Sure.
And we would tell our neighbors that. And we would say, we're not the most high quality, we're just getting started, but here's our price per week. And they were able to say, well, for that value, to have you as someone I know and I respect to come cut my lawn, I'm willing to do that. And we grew a business with that model. And so people knew what we were offering. And we said, no, we don't want to get in your flower beds. We don't like pulling weeds, but this is what we're willing to do. And so I think the transparent pricing model is also the same in medicine. If someone is aware of what it will cost, and if you say today it will cost you $100 to be seen, and in 6 months, if you're unable to pay until then it will be double. They'll probably say, well, let's just pay it now. Let's just settle the price.
Sure. So then what you're really hinting at there isn't just cost, right? I mean, what you're really talking about is a value proposition. You mentioned how, okay, here's quality, here's cost, and the two of those together, the way they interact, you end up with some sense of value, right?
Right.
In our conventional model, how do patients, are they able to gauge value?
No, I don't think they are. I work on the inpatient setting. Patients have been admitted to the hospital. They're sick, they're scared, their families are concerned, and we are offering acute care service. If the labs show a kidney injury today, we're going to react to that. And there's not really a place for us to be, also introducing here's what this will cost, because we're blind to it on the inpatient side, and our patients are in need of service right now.
Sure.
And so the value is lost to both parties, in effect. And so they find out months later what that will be. And I've had some patients say, I was really frustrated that my CT scan cost so much, because, even though, and this just happened, even though I was pooping blood into a toilet, I wasn't expecting to pay $2,000 on the scan. And
right.
So next time that happens, I'm probably not going to go. And I'm really surprised. And I think, do you understand what you're making? And then it just circles back to an informed consent. It's retrospective, where I say, well, if you know today something new from back then, maybe you could apply that in the future, but the train has already pulled out of the station. We're looking in the rearview mirror at that point.
Sure. Well, and, informed consent, I mean, that's kind of at the core of this, isn't it? I mean, we're taught as physicians that we need to talk to patients about the risks, benefits, and alternatives of a particular treatment. But are we really making sure the patient is informed if they don't know what the financial impact is going to be, in addition to the medical impact?
Nope. It's tough. It's really hard, because we are being taught, and as a trainee, there's so much just guidelines and standard of care to learn. But then you add on, if a new medication becomes standard of care, and you don't know the price of that, because it's so difficult to chase that down and to figure out per insurance company and an insurance plan and co-pays and everything else, you're just kind of making a shot in the dark. And you say, well, no one else has come back and complained to me yet, so let's give it a shot, and we'll see, how this goes. And it's really difficult, because you worry, like, am I taking the roof from over your head by recommending this medication that, may or may not be in your interest if you would rather keep your roof, buy, nice produce and maintain like a robust and healthy lifestyle.
Sure. Well, and if you don't have transparency up front and patients don't have any involvement in that process, I mean, isn't it possible that price that comes back on the back end could be inflated?
Yeah. It really could.
Yeah. I mean, one of my family members recently had to have a CT scan in the ER.
Okay.
CT of the abdomen with IV contrast.
Yeah.
And 6 weeks later, she gets this bill. And it was $5,800.
Whoa.
For the CT scan with IV contrast in the ER. Just the scan. Okay?
Yeah.
That doesn't include the professional fee from the radiologist who was reading the scan.
Right.
Okay. Now, she ended up having to have some follow-up CT scans on an outpatient basis, and she chose to go to a cash pay imaging center rather than getting it done at a hospital where they would, where they would use the insurance model.
Right.
If you had to guess, how much would you guess that CT of the abdomen with IV contrast cost? Actually, it was a CT abdomen and pelvis. The follow-ups were.
I've always been wrong when you played this game with me before. But $800.
It was $300.
$300
compared to $5,800.
I never go low enough.
No,
it always surprises me.
Yeah. But I mean, that brings us to the question that a lot of people have about affordability, right?
Right.
I mean, I imagine some of our listeners have heard about concierge practices and hear about some of these practices where, you got to be rich in order to be able to afford that. Somebody's going to pay you a retainer of $50,000 a year. And, when they're skiing in Switzerland and they twist their ankle, they expect you to get on a plane and go out there and take care of them. Is that what we're talking about with direct primary care?
No. It's different. Direct primary care, you're in the community, they're in the community. Geographically, it lines up well. And so they're putting money into your practice and you're opening your door and telling them when they can come in and see you. Like when lines up in your schedule.
Sure.
So it's more transactional and less of, this private helicopter doctor flying in to rescue you.
Right. So then, are there any particular analogies you could think of that the average person would be able to relate to when you think about direct primary care? As far as the financial piece, I mean, it's, we talk about it being affordable, but what does that actually look like?
Right. And I really like this analogy, but I like to think of a gym membership. I've heard you use that before. Sure. But you put money in and then you have access to the gym. And if you want to get a drink, you walk over to the vendor and they tell you how much the drink will be and you decide yes or no if it's worth it. But once you're in, you have access to the gym and they say, here you go. The current model I sometimes think of as like a country club subscription.
Sure.
And you pay a certain amount each year and it's a really large amount, whether or not you're going to use it or not. But then when you go in and you want to get fitted for a certain outfit, you have to pay a price just to get measured. And then you go to purchase it and they tell you, well, this is what the tailoring price was. And here's what it will cost for you to pick it up after. Sure. And, and so no longer do you have access to everything just by paying, but you have access to everything to then pay more to purchase more. And that model just doesn't fit. Right.
And then so contrast that with the transparency we see in direct primary care.
Yeah. So then what we have in, direct primary care is we have this model where, you could go and you could say, here I am and my family, and we have these comorbidities. We're looking for someone who would be able to do all the way child, all the way through a middle-aged adult. Do you feel confident that you could cover that area of medicine? And then what do you think the cost would be? And they say yes or no. If you think it's a good fit, you sign and you start making your payments, and then you can go and start to see them.
That's awesome. So as we think about gastroenterology, or some other, procedural kind of practice, or specialty, you mentioned earlier you'd like to have transparent pricing in the practice that you're going to build someday, right? But I can imagine there's somebody out there who's thinking, well, great, now I'll know in advance that my colonoscopy is going to cost $50,000 and I can't afford it, right?
Right.
I mean, what do you say to those people?
It's kind of the age-old question in medicine, and that's, it's difficult to pay for something that you're feeling asymptomatic for.
Sure.
Just this morning, I got my car out of the shop because literally this morning, the check engine light started flashing. And then we noticed that it was sputtering a little bit. We took it in. They had to repair it. It was expensive. If I had realized that at 60,000 miles, I should have taken it in and had them check the spark plugs when I didn't feel anything in the car and I didn't see any flashing lights, it probably would have been a much cheaper price.
Sure.
And so it's difficult, but if we can appreciate, and this is the age-old long game that we need to learn to play as people, it ends up costing you less in the long run.
Sure.
And what can be addressed earlier is going to be less costly in terms of health and comorbidities and recovery than if we wait until it becomes something that gets our attention.
Sure.
So
Sure.
That's usually how I approach that.
Sure. Well, one of the things that I think about is, and I don't know if you've had this experience or not, but I think about, a restaurant, right? You go into the restaurant, you take a look at the menu, and you're like, ooh, that filet mignon looks really good. Oh, but I don't know if it looks $80 good.
Right.
So you say, well, maybe I'll get a sirloin instead, right? But then you think about, and I've only been into one of these places once in my entire life, and I wasn't the one paying for the meal. So, but I've heard stories about this kind of thing where you walk into a restaurant and there are no prices on the menu.
Oh, wow.
I mean, does that mean everything's going to be free? I think it's just the other end of the spectrum,
if
right?
you're not paying, it is.
Yeah, sure. I'm paying with my time, right?
There you go.
But somebody's got to foot that bill, right? You look at it and you're like, there's no price on this. And yet, if you walked into a restaurant and somebody said, okay, here's the menu, and there are no prices on it, but you're going to have to pay the bill afterwards, would that make you feel good or would it make you feel nervous?
I'd be nervous.
Yeah, of course you'd be nervous, And would you have the assumption that, because there are no prices, this is going to be really, really affordable?
No, I would just be nervous.
Right.
And even if I was like, well, I'm just going to enjoy my meal, get what I would get otherwise, I'd have that feeling until much later.
Sure.
And so then a night of enjoying a meal becomes a few weeks of dreading the meal because you're tortured by the uncertainty of it.
Right. And then you finally get that price and you're like, that's a car payment right there.
Right.
And yet for whatever reason in medicine, so many people think that that's the way it should be. That, I should get a menu that doesn't have the prices on it and I should just deal with the outrageous bill that I get 6 months later.
It's baffling, isn't it?
It sure is.
It's tough, but like you've pointed out, like this is just, we're kind of naive to anything else. We haven't seen anything else in so long for most of us that this is just what we take for granted.
Sure. So what do you see as the path forward? Like, how do you see the conventional model evolving?
Yeah.
And then what do you see as alternative pathways?
So, yeah, I love this question. Most people in medicine right now, they think that healthcare is headed towards a system where the only way that it can be sustainable is a single payer model. And that you would then take that single payer and you would know exactly what the costs were and you would just work to drive those down. And, I suppose that's one to consider. But I've always had more of a model of seeing how prices and competition can drive quality and value. And so what I see happening in the future is that people will start to ask and they'll start to see, what is a cash price going to look like? And so if I were to pay cash for this, what will that look like? If I were to come and see you a single time and pay cash for it versus you go through my insurance, how will that impact? I think that insurance is beneficial when the all of the wellness and the preventative things are covered. That is good because then patients are more willing to do that because they don't have that check engine light and there's not so much pain. But I think if we were able to provide something similar where people were able to, at very little personal cost, they could then sit down and say, so I don't have insurance, I'm self-employed, or I've decided not to take the premiums, and I instead want to allocate that into other, more personalized ways. I could see very realistically that there would be that third column that would be the cash price model.
Sure.
Or a fourth column. So it's conventional. It would, or I guess that would be three. It would be a conventional model. It would be a cash price, and then it would be like if you were to join the direct primary care model.
Sure. And
what those would look like.
Sure.
That's what I hope it would to see one day.
Sure.
Because right now the model is to show, select the insurance price, and then if you have family or not, and then if you're in high deductible low premium, or a low deductible high premium, and it, you still have this graph. But if you were able to then see, and if I just step out of that graph and I look at what it would cost if I self-insure,
sure,
where would that take me?
Sure. So then, as we think about, the movement of direct primary care and direct specialty care, obviously you've got a lot of curiosity about that, and you have hopes of building something like that. What do you see happening with the direct care movement? Where do you see the future of that?
I think it's going to continue to grow. I'm a member of the American College of Lifestyle Medicine. And I joined that a few years back because of my interest in sitting with patients, knowing how to counsel them, knowing how to educate them, and having them accept or reject what they wanted to then take off their own health journey.
Sure.
And it's a very interesting model. And a lot of primary care physicians are very interested in it, but they get hung up on reimbursement because they're concerned. Because in large, most providers are not reimbursed. They don't have a billable code to do nutrition, exercise, sleep counseling.
Sure.
You can go through and identify if you think they have obstructive sleep apnea, order a sleep study, interpret the results, and then beat them over the head.
Sure.
to take their sleep mask. But I think that's not how people want to practice.
Sure.
And there are many who would much rather have a model where they can sit and they can be knee to knee, and they can have those opportunities to build their practice.
Sure.
Around discussions with patients.
Sure.
And so I think that it's going to continue to grow. And to get back to the College of Lifestyle Medicine, they are getting a lot of interest, and they are showing providers how to do similar models as a direct primary care.
Sure.
And there's a lot of conversation just in that one college. And then you and I have these conversations through Free Market Medical Association.
Right.
So the conversations are being had, and people are looking for ways that they can create their own practice in a different model, one that they're, the captain of their ship.
Sure.
And not so much meeting the quotas that are determined to them.
Right. So you mentioned billing codes, and then obviously, hand in hand with that goes diagnosis codes, and then, and then who knows what other kinds of codes, right?
Yeah.
The billing codes matter. I mean, do you really care about billing codes as a physician? Does the patient really care about billing codes? No. Who do the billing codes matter to?
The insurance company.
The insurance companies. And so the fact that people are looking for billing codes, I think in a lot of ways tells you a lot about the relationship between the doctor and the patient and the doctor and the insurance company.
Right.
So in a conventional model, who does the doctor work for?
Well, it's so complex, isn't it? Because before, 100 years ago, when it was a country doctor and his patients, they would sit knee to knee and they would say, do you want the surgery or not? It will cost you this much and it will hurt this bad. And these days we have doctors and patients who say, well, we can try the medicine that's totally covered by your insurance company, or we can see if they'll cover the surgery, and we can ask them. And if they say yes, then we could talk about that. And then the conversation is like, neither one of us can decide what's going to happen here, but this is how much we think you'll have to pay, and we think this is how much the insurance company will pay. So I guess we'll regroup when we find the answers to both of those questions.
Sure.
And so it's, it's really a tough model, and you're not making a lot of decisions. You're really almost scheming against the insurance company, which is tough, and it really complicates that relationship.
Sure.
Because, then I'm trying to tell you what it will cost you based on my prediction of what your insurance company will do. And then I have to tease in, and this is what the recovery from this procedure will look like.
Sure.
And so it's like a third wheel.
Yeah.
But it's a really important part for a lot of patients. And
Sure.
so it has to be addressed, but it just inevitably makes it complicated.
Sure. Well, when I was working when I was working in a conventional model, before I switched over to direct care, I would find myself in the situations just like you were describing, recommending surgery to a patient. And more often, it wasn't that we had to decide beforehand whether or not to do the surgery. It was more often after the fact, the patient coming back to me really, really pissed off because the insurance company didn't pay for it, right?
Oh, no.
And then there's all this, back and forth. And the patient's angry at me because the insurance company didn't pay. And so what we end up with is a situation similar to what you're describing, in which, the patient and the doctor are faced with a situation in which, okay, I can either do what the patient wants or I can do what the insurance company wants.
Yep.
9 times out of 10, what's the doctor going to do?
They're going to do what the insurance company wants.
And so then back to our original question, in the conventional model, who does the doctor work for?
It works for the insurance company.
Insurance company. Now, I know we're going to get a lot of pushback on that. No. I take good care of my patients. I care about my patients. Yeah, you might care about them a lot.
Right.
But you're fooling yourself if you think that you're working primarily for your patient. You're working for the insurance company, and your patient gets the benefit from that sometimes.
Well, I'll share an example that happened to my family. My wife, she miscarried one of her pregnancies, and miscarriages are terrible.
Yes.
They're extremely, they're so upsetting, and they're painful. They're difficult. And so then you add all of the emotions of it. And so she elected for a DNC to have the surgical removal and to just be done with it.
Sure.
And there we are in the hospital, and we're upset, and it's just a painful experience. It was either the hospital or like a day before. It was right before. And the doctor calls and says, "Hey, I'm really sorry to tell you this, but it looks like it's been denied." And so we're just like, what on earth? Like, this is so painful for us. And she's hurting, and she's uncomfortable. And we're just trying to get this out of our heartbroken lives. And then the doctor's like, well, I can call others, and I can try and, get you in with someone else who might provide it. And she's doing, the best that she can.
Sure.
Based on what she's being placed on. Otherwise, the hospital's not going to let her into the OR if they don't know how they're going to get paid. And we are just getting smashed by all of these different forces.
Sure.
And it's too bad. It's tough that things like that happen, and they happen all the time.
For sure. So then, we've spent a little bit of time talking about all the downfalls and the challenges.
Right.
In our conventional model. So obviously you're curious and interested in the direct care model because there's something about that addresses some of those questions.
Right.
So when you talk to, your colleagues who are curious about this, and you lament situations like the one that you just described, what kind of solutions do you see? Do you propose to them in the direct model?
So I propose to them the direct surgical model and the direct primary care model, and then it becomes, and doctors, we're really good at science, but we have to be a little bit mathematicians all of a sudden, because then we're starting to talk about finance, which is a mathematical equation. And you start to look at that and you start to say, okay, and it's interesting when you say that, because on both sides of the model, the math works out.
Sure.
And when you're trying to do the math on a conventional model, it's like all of the variables are unknown to you.
Sure.
And they'll be revealed at a later date when you least expect it.
Of course.
And so when I talk with my colleagues, I just try and share those things. And I try and say, look, this is a very real way for you to go through a career, to see patients at this pace, to be able to have this availability for your patients, to be able to, this is what you would expect to charge them on average.
Sure.
for the average sized family. And this is how much you would end up keeping
Sure.
under that model. And when you just lay it all out, then it just says, well, that doesn't sound too bad.
Right, exactly.
And that's the response that I get from everyone. They say, oh, that doesn't sound too bad.
Yeah.
Versus the current model where you're trying to learn what an RVU is. And I'll tell you this, but ever since I was in pre-med, I've always been told, and this is really what's happening, but medicine is the corporatization of medicine. And so the biggest piece of advice that people keep getting is to hire a good contract lawyer, because that's going to be the most important thing in how you practice medicine.
Sure.
I'm saying nothing against that. I think it's wise counsel, but it's very interesting that we've lost our creativity.
Mm-hmm. Oh, for sure. When you consider that physicians as a group are probably some of the smartest people in the country,
right?
And yet we can't seem to figure out how to fix this problem. And yet, I think in many ways there's a solution staring us in the face, right?
Yeah, I think we're just a little bit nervous.
Yeah.
It's an area that we're unfamiliar with.
Sure.
We came into medicine for specific reasons, and most of us were not econ majors in college, but it's not a bad time for us to start to figure it out.
Yeah. So now we've got just a few minutes left. What's your advice? If there's one big piece of advice, if the one thing that you wished you had known when you were a medical student or an intern or a second-year resident relating to the finance of medicine and the business of medicine that you now know or that you're coming to understand, because that's the bulk of our audience, right?
Right.
Those people I just described. What would you tell them? What would you tell your younger self?
My younger self. So the first thing, this was the best advice I ever got in med school, and it was from the OBGYN program director.
Sure.
Is he said, introduce yourself to everyone and share what you're interested in. If you had 10 seconds or less, that's how you do it.
Sure.
And so then you meet these interesting connections like you and I have established. Mm-hmm. Just put yourself out there, see what happens. The other thing I would say is that, it is important to be versed, even just a little bit, in the finances of medicine. Finance drives so many decisions and so much of what's happening throughout on a government level, on even just your decisions that you make day to day. And so I think it's important for us to be versed in it, to ask questions, to ask attendings and say, what are some of the greatest pinch points in your daily practice? Or what are some of the things that you didn't expect that are now really tedious for you? And, as you stay curious and you try and learn some of these things, and there's all sorts of websites and ways that you can become versed in finance, great books. But as you stay curious and you start to teach yourself some of these things, you'll begin to inform yourself on and see how you can fit into this equation.
Awesome. Well, any other last thoughts before we finish up?
I don't think so. Thanks for having me on.
Well, I'm excited to have had you here, and I'm very thankful that we've been able to develop this friendship and this relationship, and that we've been able to learn more about medicine and the finances of medicine together. And I'm excited that you were able to join us today.
Likewise. Thank you.
Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.